Maverick Physical Therapy. Welcome to a little episode 2 on the good old slap tear. We're going to re-highlight a little anatomy. I got a couple emails and a few questions on some things via Facebook and YouTube in terms of, hey, what did this and that mean, and some of it surrounding kind of anatomy. We're then going to go into a little treatment. I don't have a patient with me today, but I'm going to get my hands on a good athletic human here sometime soon, so we can go after kind of some FMR, some sling matrix related stuff, but pertaining to the function of the biceps. We talked about in episode 1 about the long head and the short head. We talked about how the long head of the biceps attaches to basically that superior labrum, that 10 o'clock to 2 o'clock position, and that 50% of that long head of the bicep tendon infiltrates into that supraglenoid kind of tubercle, and how that meshes together with the glenohumeral joint capsule as well as the rotator cuff-like complex. It's this massive amount of tissue, massive not in the sense that, hey, it's kind of meaty like the traps or the deltoid, but massive in that there's a lot of connective tissue and a highly concentrated area of tissue, like a train or train tracks going into a train station. There's a lot of intersecting connective tissue and a lot of matting and a lot of layers right here. So the typical protocol that we referenced before in episode 1 was that in regards to a slap tear, some bicipital related pathologies, is that flexion, abduction, concentric motion, that is, are quite limited in terms of a protocol, a rehab protocol. But we also took a look kind of the three-dimensional function of the biceps. And it's no wonder when we come to these related issues. So my previous and past experience with these slap lesions, these tears, grade 1, 2, 3, or 4, there's typically some form of tendinopathy that was preceding that. So tendinopathy, failed tissue healing, we talked about reactive disrepair, degenerative tendinopathies, and the thickness of those, the neural, the vascular compromisation due to those. We also talked a crap ton about scapulothoracic mobility, thoracic spine mobility, and hip mobility, and how those are essential in terms of fighting off and fending off the opportunity for one to sustain a slap tear. So we're really barking up the wrong tree. I would say 99.9% of the time that we do this, and nothing against physicians. Physicians are good at what they do, but a medical doctor, orthopedic surgeon, is good at what they do. That is diagnosing disease, so pathologies, and performing surgical intervention. What they are not great at is knowing and understanding three-dimensional biomechanics, how we get real and relative motion, how we get these properties and characteristics of this real bone motion phenomenon to give us joint motion, and what the tissue is actually doing. Therefore, it is very inadequate to and very demeaning as a doctor in physical therapy receiving a script and a prescription in terms of what a protocol, a non-customized perspective in terms of how this biceps now should heal based on what the physician has written up, which is vast majority of the time very, very bootleg. So with that being said, and a little bit more, I guess, to expand upon that, we need to know, it is imperative that in order to then, after the injury has occurred, to be able to rehabilitate the individual to a previous level of function and to maintain that consistently and efficiently well, whatever that is, we need to be able to know how our interventions, how our manual therapy, how the activity that we're giving the individual based on the success we're creating, the environment that we want it to, how it's affecting the healing process with regards to what the these physiological based principles in terms of these fibrocytes, these fibroblasts that produce collagen, all this dense protein in the body. So the body's very smart. So it'll lay down more tissue to compensate due to inflammation and injury, and it'll lay down more tissue when we stimulate it based upon the stress-strain curve, being able to overcome the forces of gravity, momentum, inertia, and ground reaction force by producing this internal resistance of tissue to load bone, to load tissue via the neuromuscular system. And so we really need to know how the body is disassociating and how the tissue is reacting and responding, and how the tissue is compensating based upon the way it's responding, based upon its successes, but then also its limitations. So a very, very typical protocol for a SLAP lesion is going to eventually have and see that individual supinating the forearm and flexing the elbow. We're going to have some, and causing, that is, hold on there just a second, we're going to get back to the functional anatomy of questions, causing shoulder flexion, causing shoulder abduction, but the bicep doesn't actually do that. So cause and effect movement is a direct response to how well the body loads. We need to look at origination and insertion point, but we need to look at function as well. So where a little confusion I think came across in episode 1 is when we were starting to talk about the cause and the control, the deceleration, the acceleration. So let's start at the shoulder first. So we know that the long head of the biceps, supraglenoid tubercle, is its origination point. Short head of the biceps, coracoid process. They come together, infiltrate, go on down, and eventually head on into the radial tuberosity. This is the left arm here, by the way. And so what that does is at the shoulder, it can cause shoulder flexion, but it decelerates extension. It causes shoulder abduction, but it controls adduction, the deceleration thereof. It causes internal rotation, but decelerates external rotation. It causes elbow flexion, but it controls the extension of the elbow. It causes supination of the forearm, but it controls the pronation. And all these can happen at a variety of different times. So we'll play around with our sling matrices. First, when I get someone kind of post-op, but let's say it was the pathology is in the left shoulder, well, they're in the sling. We're using that right upper extremity with the lunge matrix and all these positions, basically to drive that. A progression onto that would be eventually when they're able to get out of the sling, we'll go left hand on a table and then eventually left hand on a wall, basically stabilize, and I'll get my hand in there driving scapulothoracic mobility and using that right upper extremity with our lunge progressions to do so. And then we'll dig into a little bit more what I'm going to show you right now, some penny swings with a dowel, with the weight, and just straight up just body weight to go after enabling this SLAP lesion to lay down more tissue via fibroblastic-like activity to lay down collagen to get us a good solid anchor to resist deformity, but most importantly, going after the root of the problem. Crap, who cares they had a SLAP tear? You know what? If all we're going to do is sit there and crank her and play around with our ultrasound and ice and heat, stem and TENS units and stuff like that, guess what? You're not getting better. It might feel better because pain's going down. Function-wise, you're in the same boat. Biomechanically, if we don't change anything, you're hosed. So what we're going to do right now, and that's why the special tests are going to look at decelerating shoulder extension, decelerating shoulder adduction, decelerating shoulder external rotation, decelerating elbow extension. So we need to also look at, okay, in terms of the scapula, okay, what all is involved in there. So with regards to scapular function, we know that based on origination point that we can have a tremendous amount of anterior rotation probably the superior kind of glide as well, right? We can also have this upward rotation, or kind of this, let's surmise kind of this lateral kind of glide and position, like, due to the dysfunction, the impairment of the bicep. So we can do a whole lot better than bicep curls for a rehab protocol and regimen. We can do a whole lot better than bicep curls or bicep related only activities when it comes to our performance enhancement aspect of things. I know we like to see the guns and stuff like that, but there's a lot better things that we can dig on.